So thank you everybody for joining. If this is your first time joining our live echo, or if you come back, I know we have a couple familiar names, but we'll go ahead and start and just do some introductions real quick, and then we can get started with our session for today. So for those of you who don't know me, I'm Erin Montgomery, part of the outreach team here at Riley. I think I've probably met most of you via simulation and coming and hanging out in your EDs. And Kamal, you want to
My name is Kamal. I'm one of the pediatric intensivists here and part of the outreach team. I think I'm been to most of the sites that are on this phone call. I'm very honored to having worked with you guys, and Erin has been communicating with all of you throughout the whole outreach work we have been doing with you.
All right. If you guys want to go around, you want to start with Dr. Farman and just introduce yourself real quick, who you are and where you're from.
Yes, David Farman, Medical Director at Hendricks Regional. Video is off as I don't like my hat.
We like it.
All right. Mark?
Yeah, this is Mark Rolfing. I'm the Trauma Program Manager at Community Hospital in Anderson. I'm here with Allison Wilson, our ED educator. And we don't have video either because we're just not so technologically savvy.
That's all right. I think most people have their video either off or not hooked up. Brandon, you want to?
Hey, this is Brandon Glover. I'm the emergency room educator here at Reed Health in Richmond, Indiana, and I have a couple other EDRNs here with me.
Great. We've got BK Combs. You're muted though. Maybe. Emily, do you want to introduce yourself?
Sure, I'm Emily Green, and I'm the nursing educator for the emergency department at Community North.
Great. And then it looks like we have John.
Hey, I'm John Schmitz, ER physician at Hendricks Regional. I work with David. And B. Combs is Bethany Combs. She's one of our nursing managers. And I also do EMS. So in Hendricks County, I'm the Deputy Medical Director at EMS for Hendricks County.
Great. All right. And then Riyadh, do you want to introduce yourself? You're muted though.
Hi, I'm Riyadh, one of the ICU staff at Riley as well. Welcome everyone.
All right. I think that's everyone that's showing up on here. We may have some stragglers join us, but we'll go ahead and get started. So I'm going to share my screen with you guys so we can pull up the PowerPoint. Okay. All right. So for those of you that this is your first time, or if you haven't seen any of the recordings, this is our third echo session on status epilepticus. This has been a series, so this is going to be our third and final discussion. So just kind of a quick background, kind of the goal of this for everybody is to provide some pediatric education and to also kind of create a community of providers and caregivers to share knowledge and experience. So everything about this is educational and collaborative. Not here to judge anybody, but hopefully learn from each other and learn with each other. So for educational and quality improvement initiatives, we're going to be recording every session. And those recordings go to a private YouTube channel that we can then send a link out for people who couldn't make it, or to share with the rest of the staff in your EDs. So by participating, you're consenting to be recorded, but if you have any questions or anything, just please feel free to contact me. If you are on the live discussion of this, then you can claim CMEs. You get one CME or CEU for attending, and so the information is on here. You basically just have to go and set up an account, and the instructions are all on here. And then you can claim your CME, and it should just show up in your profile every time you participate in one. But you do have to claim it on the day that you attended. So you just have to claim it before midnight tonight. And if you guys have any issues or any problems with that, please let me know and I can help get those figured out. Here's our disclosure and CME statement. Just have to share with you all. So today it's going to be a little bit different. Our previous 2 sessions focused on more the clinical side of status epilepticus. Our first session was kind of signs and symptoms, diagnosis, and then our second session really focused on treatment of status epilepticus. And so kind of building on all of that, today's going to be a little bit of a different forum where we're not really going to have a case discussion. We're going to talk about if anybody's interested in quality improvement projects, if anybody's done any quality improvement projects focused on status epilepticus, and kind of just talk through some things today. So this will be as long or as short as you guys want to make it.
I really think that, as Erin was saying, the goal of the today's session, which is the final session for the status epilepticus topic, is to hear from you guys, see what you guys need or what we can help you with. We've been the last few months coming to your sites and doing the status epilepticus scenario as assessment, need assessment, and to reflect to what each ED individual needs and the overall community of practice that needs. So we'd really like to hear from you guys. What do you think is more relevant to your ED? What do you think is the most immediate or urgent need that you need? What do you like to see in regard to management of pediatric status? You guys work there, you guys are frontline defenders in the emergency department. I'm sure you know about your own needs or your own concerns or any improvement you want to do more than us. We're here to help and hopefully hear from everyone and share the thoughts. We'd like to learn from you about how we can make this going forward. And I hope everyone here will like to hear from everyone in regards to how we can make this productive beyond just 2 sessions of us talking or presenting a case. So hopefully have something meaningful out of it.
So we're just going to do a really brief summary of the 2 previous sessions of what we talked about. If you weren't able to join or watch the videos. But we really kind of just talked about what are the definitions. I think we use, the term status epilepticus, seizures, and not really knowing exactly, at least I know I do, what we're talking about. So when we say a brief seizure that's lasting less than 5 minutes, usually, that's kind of below the threshold of we're going to do any sort of medical intervention. A prolonged seizure between 5 and 30 minutes, and then status greater than 30 minutes of either continuous seizure or 2 or more sequential seizures without full recovery of consciousness between seizures. So it doesn't just have to be a continuous seizure. Some of the different pathophysiology and why do we want to talk about this with everybody, why it's an important topic, but in animal models with status have shown irreversible neuronal damage after 30 minutes of continual convulsions. And then that occurs whether they are paralyzed and artificially ventilated. And then mortality, which we all know is usually determined largely by whatever the underlying etiology is, but it can be aggravated by delayed or inadequate treatment, which prolongs the duration of the episode. And then in most recent studies where patients have been treated aggressively, they have a mortality of just 3 to 5%, which sounds pretty good to me. And then to kind of just go over treatment, and we have some resources that we've shared with you guys, whether it's been there at SimDay or on ECHO, but it's evidence-based medicine guidelines by the American Epilepsy Society, and those were updated in 2016, so fairly recently, and intended for use by clinicians, hospitals, and healthcare providers. But we also allow for kind of local adjustment based on local environments because not everybody's operating the same arena. I know you guys all know this, but just again, treatment. We have A, B, C, D. So, airway and breathing is always going to be number 1. And a lot of it's, supportive care with a lot of these seizure kids, whether it's from side effects of medication or the seizure itself, but oxygen, oral airway if needed, suction. We really want to avoid hypoxia. And then even if we have an adequate airway, it doesn't mean that we are adequately breathing. So if they're not, then we're going to breathe for them. And then circulation, we want to get IV or IO access usually pretty quickly. We've had some newer ways of administering benzos that are not IV, which is nice, I think, for our providers, but still want to make it a priority to get IV IO access. And definitely be treating hypotension. And then the D is actually for dextrose, because that's something we definitely want to get on our seizure kids. Check a glucose level, a bedside, point of care, because that's something we can do pretty quickly, and that's something that we can fix pretty easily if that's our cause. And then getting electrolytes as well, whether you're able to do it at the bedside or send it off to lab, but checking electrolytes. Here's the algorithm that we've shared with all of our sites. And again, whether it was, we handed you in person, they're on our website, but it kind of breaks down the different phases, stabilization, our primary therapy, secondary therapy, and then if they're in refractory status. And I'm not going to read through this whole thing with you guys, but just to kind of give you an idea of these are all based off of those 2016 recommendations. And really kind of breaks it down medication-wise, treatment. And then under the notes is kind of nice, what else are we doing besides just, treating labs that we want to consider, considering imaging or antibiotics. So just some kind of little notes on the side there as well. Okay, so that was a really, really brief overview of the last two sessions. If you didn't get to watch them and you'd like to, they're still up on our YouTube video, and I sent all the links out, but I can resend them all at the conclusion of this echo, so that if you feel like you want to watch them, they're available. So really we wanted to spend the bulk of this session with a discussion, and hopefully it'll be you guys talking more than myself and Kamal. But what is current practice for pediatric status epilepticus in your EDs? Like, do you guys have algorithms, protocols specific to pediatric patients? Do you have adult algorithms that you kind of alter for your peds patients? What's kind of the current practice, or what do you guys use that works for you?
This is Dr. Farman talking, and Dr. Schmitz, feel free to chime in, or Bethany if you're on. I don't know that we necessarily have a specific algorithm. We certainly have Brazo tape and weight-based, easily calculable medications, but I think that the biggest challenge that I've seen when I audit some of these status epilepticus cases is getting the medications either in a drip form, or the unusual medications that we don't necessarily carry in the emergency department, Pyxis machines from the pharmacy in a timely fashion. When I talk with the physician or the nurses who have cared for these cases, oftentimes one of the frustrations arises from having ordered medications electronically, and then there seems to be a prolonged delay in getting those medications from pharmacy. And so I'm not sure whether at Riley or at other larger institutions, whether more of these, quote, unusual medications, and for us that would be unusual, like the barbs, that sort of thing, are actually stocked in the emergency department, or whether they're stocked elsewhere in the hospital and have to be mixed and then transferred down to the ER.
Yeah, that's a really good point, actually. It makes me even think more about, just to be more clear, you're talking about the second agent of seizure management beyond the benzos, like whether it's a Keppra or phosphonate or phenobarb, right?
Yes.
Yeah, absolutely. So at Riley, if I'm remembering correct, we have the phosphonate, I think, in our Pyxis, and the Keppra has to come from the pharmacy, and so that makes the second agent, which is phosphonate, based on the guidelines, readily available in the unit if we need it. Some of our providers would prefer Keppra, just given the better side effect profile. So when we order it for that reason, it takes probably 30 minutes, sometimes 40 minutes to come from the pharmacy. But I totally understand in the ED setting, when the patient is actively seizing and order to receive 2 doses of Ativan, the use of second agent will become critical at that time. So would you remember what's like the time delay estimate for this medicine to come from pharmacy?
I would say it was between 45 minutes and 60 minutes, and I think that One of the challenges that we ran into is, it's kind of off the top of my head, the child was seizing, benzos were given, IV access was obtained, child was intubated, LP was performed, orders were given for multiple benzos, and then multiple orders were placed at the same time simultaneously into the EMR, some for empiric antibiotics with the presumption that the child could have meningitis, and some were for the anti-epileptic medications. One pharmacist at night all of a sudden gets multiple medications that they're supposed to mix and send down in a timely fashion. And so I think the antibiotics came first, but in hindsight, it would have been nice if the anti-epileptics had come first. And I don't know that we necessarily had an algorithm or a protocol for this. And so I was just curious to see whether anyone else has run into those issues with trying to obtain multiple pediatric either drips or mixed medications from pharmacy in a short time frame, and whether they have any advice on how to manage these type of situations in a smaller hospital.
Is that pretty standard as far as in the emergency department that just for anybody else that you wouldn't have access through the Pyxis or whatever to stuff like phenobarb, Keppra, all that? Is that pretty common?
Yeah, for us, I would say phenobarb and Keppra aren't necessarily going to be stocked in the Pyxis. And we've had some discussions about that, but yeah, I mean,
yeah,
I
it
wonder.
doesn't come up very often.
Sure.
Yeah, absolutely. I wonder. I mean, I'd like to hear actually from other EDs how they approach this. Number one, if they have the same issue, and number two, if they do, did they have any mitigation plan for this? Because I personally think, like, and again, I'm thinking from academic center, pediatric, center standpoint, that would it be feasible to have one agent, the second agent, either phosphonate or Keppra, readily available for this situation? Because I totally agree and echo your concerns. I want to get antibiotics or in timely fashion. At the same time, I think giving anti-epileptic at a timely fashion is as critical as that. Would it be feasible to have at least one agent of the second line for anti-seizure readily available? I wonder what other ED practices or issues have been like.
Sure.
Yeah, I've been in some EDs where they have pharmacists that are down there, and I think that's kind of a neat model where the pharmacist is at the bedside helping to dose meds, and they're not off in a different area of the hospital. They're there right at the bedside with the patient, which can be helpful in getting things done quicker. I think that's a neat concept.
I was going to say at Community North, on our day shift hours, we have a pharmacist in the unit, which helps with a lot of that. But they leave, it's around 9 to 11 o'clock at night. So for night shift, it is sometimes an issue to get those medicines in a quick enough fashion.
Yeah, and at Reed Health, during our medical alerts, the pharmacist will respond at all hours of the day and night. They still have to mix that stuff down in pharmacy, Keppra and Phos. So it does take a little bit of a delay, but I think it helps because it's going from pharmacist to pharmacist and they expedite it. Knock on wood, we haven't had any delays with that.
Kind of like the idea of having on either medical alerts or pediatric alerts, having a pharmacist that actually comes to the patient's bedside. It's not a bad idea.
Yeah, the question I have for you guys actually regarding the model of practice, would the pharmacist come to certain patients when they come to your ED, or they only come to the patients who come like with SI 1 or 2 or the trauma bay? How do you guys utilize your pharmacist for certain population in the ED, pediatric population?
Ours is most at the discretion of like the charge nurse or the physician. If they feel like, it'd be beneficial to have the pharmacist at the bedside, they've always responded and been happy to do so.
Same with us, and they're constantly watching the orders. So if there's a set of orders that are put in that they think they need to go to the bedside to help with, they're very responsive to that.
No. We currently don't have pharmacy respondents to our emergency department.
Okay. Lauren, can you?
I can hear you guys. Can you hear me?
Yep.
Okay. So I got to clarify a couple different things. So we have Keppra stocked and we have phenobarb stocked in our peds trauma room at Hendricks. Both are there. Pharmacy is on our alerts. They are on our pediatric alert. So if a pediatric alert is not broadcasted, then they won't get that. They won't know to come. What I'm going to institute, because we also have problems with Vocera working, there's a lot of dead spots. So now, from now on, if we have a patient, any child in the pediatric trauma room, I'm going to have the unit clerk notify pharmacy and have them send a pharmacist down to us. We have had that in place in a couple of the codes I was in, and it worked wonderfully. We had no delays on meds. The pharmacist was actually pulling up the meds for us. If it was something we didn't have stocked, they were getting them immediately because they were frontline right there, and able to call down and say, I need this immediately. So I'm going to have the unit clerks do that to alleviate some of that. If we have a pharmacist there, I think it'll make a big difference. My thing is we do follow like the ones I've been in on. We've pulled out your chart, like your pathway, and we have followed that all the way through, which is really nice. And then what I was going to say is when we get to the point where we've given 2 benzos and we're at the point where we're ready to pull out Keppra, should we go ahead and just preemptively like mix up the pentabarb or the Versed drip, whatever, route the intensive. At that point, we're usually on the phone, even thinking of transfer too. But like, is that something we should go ahead and already be pulling? Is that something that would benefit us? Just because unless you see a lot of times patients come out of refractory with Keppra, then I don't know if that's something where we end up wasting it, or is the majority of the time they're going to need that next step for maintenance on transport? That was my question.
Yeah, I'll be happy to add my input to this, but I would like to hear if anyone else actually have certain input about this one. I think this is a really good point because hard for me not to say my input. I'll say my input first. So it's part of the investigation process. I agree, Lauren. It's a really good point that once we know that this patient will likely need a second agent after the first or second dose of Ativan or benzo in general, there's got to be a process to be able to have this medication readily available through a certain notification process. Now, well, it becomes tricky because what if you have a patient that has a history of seizure, a lot of breakthrough, or what they need to get 1 dose of benzo? You don't want to try to utilize or occupy the system and the pharmacist with something that you may not use eventually. But I really think once we give the first dose of Ativan and the patient still seizing, when we think about the second dose, this is the time that in general we should be thinking about, I need to work on my second agent, because if this second dose of Ativan is not working, nothing else is going to work. And when it comes to benzo, I have to use a different agent, and especially for kids with history of refractory seizure or a lot of breakthrough seizure with development delay, the response to benzo only may not be optimal. So it's going to be very dependent on certain EDs that will have that luxury of having a notification process to the pharmacist after the first or second dose of benzo or not. So we'd like to hear from other EDs how feasible they think this will be to apply or utilize in their own EDs in different ways. Anyone can talk. It's really mainly to reflect to what you guys think will be limitation for this. I mean, it's not expected for everyone to be able to do the same, model of care, but just to see what's different and what's relevant to the group of EDs together.
have many people gotten to the point where you've given 2 doses of benzo, you've given an anti-epileptic, and then you're thinking about refractory status and potentially escalating to penobarb or Versed drip? I'm just curious.
I don't think it's often, but I will say most of the epileptic patients or status patients we've transferred out have reached that point to where we maybe did not start it here in Hendricks, but I will say the transport team has started it if we haven't. I've noticed that that's been one of the first line meds they come in is we've already given our benzos, we've given our Keppra, or even phenobarb, and then I've seen them pull out or hang a Versed drip or hang a penobarb drip. And I had one time actually got a penobarb drip from the pharmacy here and had it ready for them, and they arrived at the same time, so they went ahead and hung it. But I think the trend that we've seen lately is that these children are following more on that route and getting to the refractory phase much more often than we used to in the past. It used to be that we kind of saw just your typical febrile seizures. But I think as we have grown, and I think that as the word has gotten out into the public too, and the EMS feels comfortable with us, that we've been seeing a lot more increase in seizures with kids.
Does anyone else have a point of having to just give an anti-epileptic and then you're still not able to stop the seizure? I'm just curious for conversation. Or do you guys normally see, once you've given Keppra or phospheni or something like that, either they're gone or you've seen good reaction to that?
I've personally seen usually a halt of the seizure before their transport out, whether that be from first line or second line. We can usually get at least a better response from the kid. And then I often see our providers ordering those second line meds early, just for the instance we were talking about early, some of the delay it might take. It's one of those things you can never be too prepared for.
And then this is a good point. I look at it, the same way when I manage sepsis, like when I'm giving the second bolus of fluids, I am already ordering my vasopressors or whatever inotrope of choice I'm using. The same for this. When I'm having like a refractory seizure in the unit in the ICU, once I'm giving my first Ativan, the kid's still seizing, I'm already thinking ahead of time about what's going to be my second choice. It's going to be the Keppra or phosphonytoin. And if that doesn't work, am I going to order a Versed drip or a penobarb drip or propofol drip? What's going to be my drip choice? So it's always good to think ahead of time, because getting the second agent is one thing and getting the drip ready is another thing. So having that probably mental model and brain to think of what I'm going to be doing is a big point. I appreciate that you're adding that.
Okay. So it sounds like potentially utilizing pharmacy, if possible, could help mitigate some of the delays, potentially, if you have that available. And then, Lauren, did you say that you guys do have access to second-line agents in the Pyxis, or?
Yes, we do. We have phenobarb and Keppra both in our Pyxis.
Okay. And that was just another thing that because coming from a transport background, we have phospheni, phenobarb, and Keppra, and we have to mix all of our own drips. Obviously, it's a little bit of a different arena, but maybe, like Kamal was saying, choosing one and having that available in the Pyxis if you are seeing huge delays from pharmacy, or it's something that takes a while, you don't have pharmacy at night, or whatever it is. But then you also have to kind of talk about, as far as education with nursing or the staff who's going to be mixing up those drugs, resources for them to kind of mix them up. But just another thought, at least maybe stocking one in the Pyxis. And I don't know what the process is to go about changing something like that. Probably painful, I would imagine. But could be a potential option to have quicker access. Does anybody use like order sets if you have a pediatric status patient come in that you just go click through, or is it all really enter what you want? If you guys know.
That would be a Dr. Farman thing, because I'm not sure on their side what their what Epic's order sets look like, if there is one that's actually for a status patients or not.
Yeah, we don't.
I didn't think we did.
Yeah, we don't have any order sets we utilize either. It's doctor specific.
Okay. Potentially, I mean, you guys have one that you use.
Yeah,
I don't know if that would cut back on time of anything.
Yeah, probably order set wouldn't. I don't know how to look at the order set in the ED department, the ED area. In the ICU, it's more continuity of care, so it helps with the whatever subsequent step we have to do when it comes to managing a seizure or another disease. And the ED is more of a whatever you need to provide in the first golden hour, or whatever you guys call it. So order set maybe have some utility in the ED or not in regards to the status. I think I'll totally defer that to all of you guys to see if that's something relevant to you. It looks like to me from overall hearing from everyone that having a pharmacist that is available for these patients is also a good value in this management, not only to help with getting the medication ready, but also help probably preparing this medication and having that multidisciplinary approach in the AD to acutely ill pediatric patients coming with status epileptic or refractory status. So it seems like there's more excitement and more emphasis on the value and the utility of the pharmacist and these circumstances. And the availability of pharmacists is probably variable among different EDs. We are at the ICU at Riley, we're lucky to have our own clinical pharmacist that is almost always available for any of those crushing situations. It's probably different in the EDs when it comes to pediatric pharmacists or pharmacists that can help with a pediatric patient.
And then for those who don't either have pharmacy that can come to the bedside, or maybe in the meantime you're waiting for pharmacy, do you guys have? I know Dr. Farman said you guys utilize a Broslo or like a med calc sheet. Does everybody have something like a medication calculator that's available to use, or Broslo or something as far as dosing, specifically your benzos, because that's what you're going to give first? Or does anyone want to implement something?
We have the Broslo, and then we have a computer-based system, and then some sheets, medication sheets as well.
Okay. Cool.
I know a lot of folks use apps too. I use PDStat and PDSafe, which I feel are really good apps. Some of our EMS crews use HandTevi to help with dosing and stuff like that. So I know that that's a real popular one right now in Plainfield, is the HandTevi dosing system.
Yeah, I mean, we looked at a couple of different options. I know, Aaron, we were working together for a little bit trying to find a good computer-based dosing sheet that we could print out for any pediatric patient after we input their weight and everything. But I see the physicians more often than not use just a phone app. I think PDStat, most of them have, or something similar to that. And then, of course, Broslo.
I'll put the link to the HandTevi thing on the chat, so if anyone wants to look at it, you can click on it. It's pretty slick.
Thank you.
That would be great. No, absolutely. I mean, it's really very eye-opening to me personally, because we are spoiled by having all the resources and the personnel that we need in the pediatric hospital and children's hospital. But sometimes we lose that reflection and reality of what our community partners need. And again, I always bring the example of, if you ask me to take care of an adult patient, I would totally fail because I'm not trained and I shouldn't be taking care of an adult patient. But you guys are well trained to take care of pediatric patients, but you work in different environments than us, the mainly pediatric providers in the academic center. So it's always good to hear what you got utilized and use. And very impressive to me that a lot of your sites using some resources, some online apps, or printed sheets that use the weight base for medication calculation, which is it's extremely helpful to all of you, given that you have different level of resources and support when it comes to that. So appreciate everyone sharing their thoughts about this, because I think this is a very important point when we go. We've been through a lot of EDs in the state of Indiana, and we notice very different and varying practices and different needs in different EDs. So it's good to hear from a spectrum of what I call you guys core community partners, which is all of you here about how you do things, and more importantly to hear from each other how you guys do things. There you go.
So again, this is more, I know we talked about kind of the medication piece of this, but
a sleeve that goes over like the vials and things like that. We've just got those added to each one of our PALS carts here in the hospital, and staff have been really receptive to it. I think it's a good tool. I can post that link as well.
Awesome.
Yeah, and probably that really one probably will ask at the end of the session, actually, if we can have actually the group email from all of you guys to send us, if you want to share any certain resources or links that you'd like for the group to have, if to send it to us, actually, that would be great. If you send it to Erin will probably distribute them afterwards, but feel free to share anything with us in the meantime.
So I know we talked about kind of the medication piece, and certainly we can continue to discuss that, but is there anything else that you guys have found, whether it was when you were caring for a kid in status, or reviewing charts or whatever, of if there were any barriers to kind of provide care or follow appropriate algorithms, whether it was equipment, again we already talked about access to medication, resources. Is there anything that has come up, or anything you guys want to discuss, pick people's brains?
I think a big challenge from the community setting with pediatrics as opposed to adults, because our adults with status get admitted to our hospital, but all the pediatric ICU cases would be transferred, is if you have a kid that's far along the spectrum where they do have to be intubated, is trying to the challenge of trying to evaluate for subclinical status. And if we're admitting an adult patient, it's pretty I wouldn't say easy, but it's easier to get an EEG, and so you've got all that kind of going on behind the scenes. But trying to get an EEG on a patient that's being transferred and managing drips and evaluating for subclinical status, I think can be very challenging. So I've always found that a challenge, taking care of these kind of patients.
Yeah, absolutely. And remember, this is a really important point, because once we intubate them and they receive sedation and muscle relaxant for seizure, we have no clue if they're seizing or not. We assume they're not. Some of us assume they're seizing, and getting EEG for that short period of time, by the time probably you call the TIC and get the EEG lead on and have the read, it's a time for them to be transported. So I totally hear your concerns about how can we better utilize the EEG there, or do we need to utilize it there? If you have a transport, transport waiting time of 30 minutes to 45 minutes, and by the time the EEG TIC will be there, if the kid is ready to go. I mean, again, it's hard for me to make any recommendations or any practices, advices, but it's maybe just ideal to, in that time, I assume that the kid is seizing, and if he got a dose of Ativan, getting a second dose, first dose of Kebra or phosphonatoin, that hopefully will take care of the seizure for the next half an hour, 45 minutes. I think what we can do better is, if they got Ativan and they got intubated, 3 or 4 doses of Ativan, which is above the recommendation and the guidelines, and they got intubated, they should be getting a second agent regardless whether they're seizing or not, because I have no way of assessing if they're seizing or not. And I would like to hear actually from Dr. Lutfi, because he used to be our transport director, and I'm sure he dealt with a lot of similar issues about, during transport, if the kid is intubated, sedated, and paralyzed, how do we know if they're seizing or not? Or what do we do? What do you recommend from a transport standpoint that can actually be relevant to the ED environment, Dr. Lutfi?
Yeah, I think this is a really, really good point, which we struggle a lot in the past, mainly because some of our neurologists recommend, oh, it's a first seizure. We're not sure we need to load those kids. If we're not sure they're seizing, I want the EEG. And he brought a really good point. What do I do when I know I'm transporting those intubated children who could be paralyzed for an hour or even more, and they got intubated for seizure? I think just reviewing so many charts and knowing that transport can take a while and things can get a little bit more time than what anticipated, I feel like the best for these kids to be loaded with one of the drug, because if they're sick enough that their seizure led to be intubated, I would love to have them on Keppra or phospheny, at least to cover the transport period. And then, yeah, sure, if they're paralyzed, we're not going to know if they're seizing or not at this moment, because you're right, the EEG is not very applicable here. If you're trying to get them out, you're not going to be able to get EEG. And at this time, we don't have EEG on transport. We don't have a transport personnel who read EEG, even if we placed it. So for me, I think if they're sick enough to need a breathing tube, they deserve to be loaded with one of the second agent, either a load of Keppra or phospheny for a transport. And perhaps we don't need to continue at Riley if they're awake and they're moving, or we have the EEG in place to prove if they're seizing or not. But this is my practice so far, who's not greatly supported, because I think it is case by case. If I know they're going for a 3 hour of ride, I like to have some anti-seizure on board.
Has anyone else come across this where you've gotten to the point of, you've given second lines and getting EEGs in the ED on PEDS patients? Is that something that anybody else does? I'm curious, because Hendricks is fairly close to Riley, but some Brandon, you guys have you're a little bit farther out there in Richmond, not to call you out, but is there anything else anyone else has done or seen or had the same issue?
We're not currently doing any EEGs in the emergency department up here in Anderson. No.
Are not?
Yeah, nice here in Richmond.
Okay. It's tough.
And how do you guys feel about giving a second agent somewhat blindly when you don't know if they can see them or not? Like, assume he got 2 or 3 of Ativan and you're intubating him and the seizure clinically stopped, right? I would personally feel very, very encouraged to give this kid a dose of, Keppra or phosphonatoin. Would any of you guys feel that this would be something that you wouldn't be feeling comfortable to do, or you feel very comfortable and confident doing a dose of a second agent dose, despite not having the objective sign of seizure, but knowing that you intubated for the seizure? Would anyone feel opposed to that? It's not a trick question, it's a real question. I don't know the exact answer, so anyone is welcome to say.
I don't think there's any hesitancy to wanting to give those second line meds for us.
No, I wouldn't have a problem with it either.
Okay, very good.
All right, what to do now? So I think we've had some really good discussions. I don't know if some people, are being a little bit more shy, maybe don't want to chat. Kamal and I are happy to help if there are certain gaps or barriers that you found when treating these kids, or if something comes up down the line where you have a seizure kid come in and you identify something that maybe could be helped, then we are certainly here to help with resources, whatever kind of is that you guys might need, training tools. Another question I was going to ask, and I know we've seen this more in EMS, but curious from ED as far as intranasal Versed, is that something that everybody's been using if you can't get access or don't have access? Just curious if people are using it. And comfortable with it?
Used it. It's not something that we've used a lot of. Oftentimes there's a little bit of a funny look that you get if you ask for some intranasal medication, but if you walk people through it, it usually goes pretty smoothly.
Yeah. Anybody else using intranasal Versed? Or has anyone else talked about it or not exactly sure what it is?
I don't know. We use it for probably typically for other things. I don't know that we've had a lot of conversation around using it in this application, but we have it available if we wanted to use it. Because we're just not using it typically for this.
And from like a nursing standpoint, do you think like nurses are comfortable using it? I mean, it's a little bit of a learning curve, like Dr. Farm said. Some people might give you some weird looks when asked for it.
Yeah, I think initially there was a little bit of a learning curve, but yeah, I think they've gotten kind of used to it, more comfortable with it for sure.
I was just curious because that's another thing that some sites have asked us for is just kind of some help with education around using it and how to use it, and that it's even an option for those kids that either you don't have access on or you're having trouble getting access or in the process of getting access. So kind of moving on from here, if there's specific things that you guys want to work on in the ED, certainly we're happy to help. And again, like I said, if more questions come up or things come up as you guys see patients or review charts or whatever, we'd love to help and kind of, have a community help as well.
The question actually I have for both you guys, if one or two sites can answer this, is if you have the chance or the opportunity to work on one thing in regard to pediatric status epilepticus in your site, what would be the thing? Like, what would be the one thing that comes to your mind that say, I wish we can do this different or do this better or have a plan for this or that? What would be one thing after this discussion, if anyone has anything to share with us? It's an open podium. Anyone can talk.
So I think our goal here at Reed would be just to start the second line medications earlier.
Okay, very good. Anyone have any questions or suggestions or thoughts or anything they want to share with us? Any story about, speech status epilepticus or any random thought about this you'd like to talk to us before? Okay.
I had a couple slides on like QI stuff as far as like smart aims and PDSA cycles, but we're kind of getting close to the end here. Happy to kind of talk about this. As you guys know, I'm always available and everybody has my contact information, so please don't hesitate to reach out. If I don't have something for you, I can find something. Got questions? So kind of coming to an end of this, we're calling it our Status Epilepticus series. We do have, it's kind of the same survey that we've had after each session. It's very brief, and we've gotten some really good feedback so far. This is only our third session ever of doing anything like this, so we're really looking for any feedback to make it better, to make it, we want to be respectful of everybody's time, and we want to make sure this is worthwhile and everybody's getting something out of it. So if you guys, and I'll send this out via email as well, but if you guys wouldn't mind, it literally only takes a couple minutes. And if you have anything from the entire series or about the ECHO program, please feel free to share that with us. We would really, really appreciate it. And then here's my email again. If you guys don't have it, you probably do because I send a bunch of emails out about this. But please don't hesitate to contact me. Our next session next month is going to be July 18th at noon. and this is going to start our sepsis series. So it's going to be kind of modeled the same way. Our first topic will be sepsis in the pediatric patient in the ED, so recognizing signs and symptoms, and kind of focusing on how those patients are going to present to you guys. And that's going to be done by one of our pediatric emergency medicine colleagues from here at Riley. So we'll be switching gears a little bit next month. And if anybody's interested in presenting a case for the next session of a septic pediatric patient you guys have had in your ED, please reach out to me. I promise we can do it together. We'll walk through it. We're not going to like leave you high and dry. And just, you know, looking for any sort of cases, anything interesting or relevant to share with everybody, and hopefully have another great discussion. So, and then I will send out the link for the recording so you can share with anyone who wasn't here. You guys have any other questions or anything before we hop off?
Thank you.
Thank you everyone for being here. We'll see you next month.
Thank you.
Bye.
Thanks.
Can save them? You can.
I guess I could probably copy and paste it. Right?
Oh, yeah. Yeah. Good job.
That was a good
Thanks.
one.
Good one. Yeah. Good one.